We'll give it 1 minute. Everyone, welcome to our September 2024 AIDS Clinical Conference. I'm delighted to introduce our panelists this morning, coming from near and far. So Aley Kalapila, she is a former graduate of University of Washington Infectious Disease Fellowship, but she's based at Emory now and works at the Madison Clinic, where she's an associate professor and HIV care provider. And so she's joining us from Atlanta. And then we have Dave Hachey, who many of you know through our Mountain West Echo community as one of our expert speakers, coming to us from Idaho, where he's a professor and pharmacist and AAHIVP as well. And then we have Stephen Johnson coming to us from Denver, where he's a professor of infectious diseases at the University of Colorado, and also joins us on Echo occasionally. So, and then I'm Shireesha Dhanireddy. As most of you know, I'm here based at Madison Clinic here in Seattle. So today we're going to tackle some clinical controversies and challenges. Obviously, there are a lot, and we only have a finite period of time this morning. So we've chosen a few topics to discuss, and we have some very timely updates, fortunately, even for within the last week. So we'll get started. So none of us have any conflicts of interest. And then here's the acknowledgement for the Mountain West AETC that's supported by HRSA. And then we'll get right into it, to our first case. And this is a 27-year-old cis male who presents to the emergency room with headache worsening over the last few weeks. There's a past medical history that's significant for opiate dependence, smokes fentanyl, and he uses meth, injects, and smokes. He lives in his car and he has sex with men. While in the emergency room, the rapid testing for HIV is noted to be positive, and he's admitted for further workup, given his headache that's been worsening. Subsequent labs show a CD4 count of 4 and a viral load of 350,000, and his LP shows an opening pressure of 36, has 17 white cells in his CSF, no reds, and an elevated total protein of 111. His serum CRAG and CSF CRAG come back quite high. So, anything else you would be worried about in this patient with advanced HIV and headache? And then I wanted to kind of have our speaker, Dr. Kalapila, walk through our preferred management of cryptococcal meningitis.
Okay, well, thank you. So yeah, this patient has advanced HIV. His CD4 count is 4, and he's presenting with what sounds like a subacute headache. So this is something that we very commonly see in Atlanta. You know, I always kind of emphasize that when someone has this low of a CD4 count, there are multiple things that need to be on your differential, and you can't sort of necessarily anchor to one, although we definitely have a diagnosis of cryptococcal meningitis with his low CD4 count and the subacute headache and the positive CSF CRAG. But other things that I would think about with this kind of presentation, you know, I kind of like to organize things by like bacterial, viral, fungal, parasitic. And so in the bacterial bucket, the big one that I would think about would be neurosyphilis. And so that certainly can happen in someone with a subacute headache and that low CD4 count, who's at risk for exposure to syphilis. I would also think probably about toxoplasma encephalitis as well. Usually you would expect that to have maybe some focal neurologic deficits as well, depending on the site of the brain lesions. I'd like to know if this patient had a positive serum toxo IgG and also any abnormalities on like head imaging, which hopefully was done before he had his lumbar puncture. Those would probably be the two most big things that I would think about. But you know, we have if he had altered mental status, obviously things like bacterial meningitis, typical bacterial meningitis like pneumococcus, meningococemia, HSV meningoencephalitis, all of those things are definitely can coexist in the same patient, especially with this low of a CD4 count as well. And then as far as I guess we can talk about diagnosis. So, you know, I think the first thing obviously is to get a head imaging to make sure that there's no evidence of increased ICP. Provided like a non-con head CT is negative, I think it's reasonable to do that lumbar puncture. And obviously when crypto is on your differential, you're going to want to get your opening pressure. The best way to do that is to make sure that the patient is lying in a left lateral decubitus position, because that's the most accurate measure for your opening pressure. And then of course, once you get that, the things that I would normally send off for would be your routine bacterial fungal and AFP cultures. I usually will send off for your cell count, diff, protein, glucose, all of those standard things. Actually, here in Atlanta, we still have an India ink that we do at Grady, which comes back faster than our Crag. And so I normally would get that as well. And that's a stain that looks for Cryptococcus. And so I would do that here. We now do the multiplex PCR, which can look for viral etiologies and can also pick up Cryptococcus, although it's not very sensitive. So if the burden of crypto is low, it's not going to pick it up. So then in those cases, you would want a serum cryptococcal antigen and a CSF Crag as well. I think I have most things. I don't know if anyone else wants to chime in terms of other testing that they may want to look for.
No, but I think your point about imaging before LP is still important, given the prevalence of multiple opportunistic infections that people can present with.
Yes, yeah, absolutely. And then as far as the medicines are concerned, so typically I think about, so these are some great resources in terms of the OI guidelines to look for, how you would treat cryptococcal meningitis. So you have your OI guidelines. WHO is also a good resource, especially if you're working in resource limited settings. And then the National HIV Curriculum, which I'm an associate editor on. And so we also try to keep that up to date to reflect or summarize the OI guidelines as well. So the treatment for cryptococcal meningitis can be divided up into 3 sections. And so the first one is your induction. So this is actually your most intensive treatment, and it consists of 2 weeks of liposomal amphotericin along with oral 5-flucytosine. And the goal for induction really is to sterilize your CSF. So we administer this for every 2 weeks, and you want to document sterilization of the CSF at the end of your 2 weeks of induction. And then after that, you have your consolidation and your maintenance, which are sort of less intensive phases where you're actually going to be using oral fluconazole. Typically, you use like a higher dose of fluconazole for about 8 weeks. And then after that, you can get to a maintenance dose for which is about 200 milligrams of fluconazole. And you're going to continue that till the patient actually has adequate immune reconstitution and viral suppression on ART. So that's sort of the broad strokes for cryptococcal meningitis treatment. In addition to that, when you are, okay, we're going to go back to
Go ahead, Aley, if you had another comment to make.
Yeah, I would just say that probably when you're going through your induction phase for cryptococcal meningitis, I think other things to keep in mind. So this is obviously a disease where patients can present with high intracranial pressures. So I think from a management perspective, you are going to be repeating your lumbar puncture as you need to and drain that CSF down to a normal opening pressure if the patient has a high elevated intracranial pressure. There will be certain circumstances where patients will just have persistently elevated pressures because their burden of crypto is high. And I have seen that many times. In those cases, if you have to frequently do LPs, inevitably you will need to get neurosurgery involved. Usually in my experience, neurosurgery will put an external lumbar drain first until you're able to sterilize the CSF. And hopefully at that point, your ICPs are low, but if they're still persistently elevated, then neurosurgery will go in and put a BP shunt in the patient, given their persistently elevated intracranial pressure. So that's probably the other component of cryptococcal management that you want to be aware of when you're managing someone with cryptococcal meningitis.
Oh, and before I go to the next slide, Dave, did you want to comment about the 5FC?
Yeah, a lot of times we don't use a whole lot of 5FC, in regular practice, and it does have quite a few toxicities, and it's really important to make sure that you have that patient well engaged in care so that you can do regular CBCs. And the big thing too is monitoring the creatinine clearance, as flucytosine can have some toxicities, and even in some cases monitoring serum levels and adjusting doses based on that and based on changes in creatinine clearance. So that's I think that's the big one there. And I think we can talk about some issues with fluconazole a little bit later.
Yeah, and I think that like whenever I put the patient on induction, at least at the hospital that I work at, and I'm sure at Harborview and other places too, like normally the amphotericin, when you dose the liposomal amphotericin B, it comes automatically with sort of aggressive pre and post hydration, and also like at least BID labs, because you can get, as you know, significant electrolyte wasting as well. And you obviously, as Dave said, want to monitor the creatinine clearance as well, because it can definitely be affected even with liposomal amphotericin B.
Great. Well, thank you so much for that overview. But of course, you know, things don't always work out optimally. What the guidelines say is not always feasible. This patient, he wishes to leave the hospital as he's worried that his car will be towed. And as a reminder, he lives in his car, so that's his home. So he is very motivated to leave, but he agrees to return to clinic to resume care and agrees to take whatever medications you prescribe him when he leaves. So this is an audience poll, and then we'll have our discussants speak about these options. So please answer. So which of the following would you recommend? Allow him to leave as a patient-directed discharge with a single dose, with just high-dose fluconazole, 1,200 milligrams per day. Decline discharge and recommend he remain admitted for 2 weeks for the induction that Aley talked about with the 5FC and monitoring and documenting of clearance, or give 1 dose of ampho and discharge with high-dose fluconazole plus 5FC. And so looks like we've had a few respondents here. We'll give it a few more seconds. All right, let's end the poll and share the results here if we can. Can we share those results? Maybe we can't share the results.
Oh, I can see it. Can you
see them?
Yeah.
I can see the results. I just didn't know if
Okay.
everybody else could. So 36% of you said allow him to leave and give him the oral fluconazole. 5% were in favor of declining discharge, so keeping him even though he wanted to leave. And then 59% wanted to give a single dose of amphotericin. So let's have our speakers talk about this, these options.
Are we doing the clinical trial later, Shireesha, or are we going to talk about it?
We
Okay.
can do that. Yeah.
Okay. Because I thought this would be a good preface to then like a discussion, because I have strong opinions about this. But so this was a clinical trial that was published in the New England Journal of Medicine in 2022. And this was a randomized clinical trial that was done in sub-Saharan Africa. So remember that in resource limited settings, the WHO recommends the standard of care for cryptococcal meningitis is to give 1 week of regular amphotericin B deoxycholate, so not the liposomal formulation, and 5FC, followed by then 5FC plus high-dose fluconazole for a week. Now, this is because in sub-Saharan Africa, it's very difficult to get liposomal amphotericin B. So this trial was done where it compared the standard of care, which was this 1 week of ampho B and 5FC followed by flu to a single dose infusion of liposomal amphotericin B at a high dose, so about 10 mg per kg as opposed to the 3 to 4 mg per kg that we would normally do if we were here in the US, followed by 2 weeks of 5FC and high dose fluconazole of 1,200 milligrams. And so the primary endpoint for this was death from any cause at 10 weeks after randomization. They enrolled about 840 people living with HIV who had their first episode of cryptococcal meningitis. And what they found was that a single high dose of liposomal ampho B was actually not inferior to the WHO recommended regimen. That there was similar fungal clearance in both groups, and fewer participants in the single dose liposomal amphotericin B group actually had severe adverse events compared to the group that received standard of care. So this is definitely like a great option to have in your back pocket, especially when you have patients that feel that are reluctant to stay in the hospital for the entire 2 weeks of induction. I was pretty excited when I saw this data, and actually I had a case last year of a patient who actually was almost exactly this scenario. He had to leave and he really did not want to stay. I will tell you that we really struggled with him because the fact is that this is a ton of pills. The fluconazole is like 6 pills and the 5-FC is also like several pills. And the reality is that the patient, in my case, like he didn't actually take his medication. And unfortunately, he's now readmitted with both devastating crypto and PML. And so I just think that I think it's a good option if someone is reluctant to leave, but if you can somehow or the other convince them to stay and receive their 2 weeks of induction, it is going to be better for the patient in terms of, I think, personally, sterilization of the CSF. But if someone is actually willing to commit to taking this number of pills, it's definitely a good option to have in your back pocket. It's just my opinion.
And real quick, here in Idaho, during the pandemic, we had a patient who was newly diagnosed with asymptomatic cryptococcal meningitis, who is older, and we did not want to admit to the hospital for 2 weeks for fear of contracting COVID. And because of that, under guidance and conversation with the ECHO team, we decided to do a single high dose of AmphoB with no flucytosine and just high dose fluconazole. Luckily, the patient did very well, was able to clear. And again, Idaho being a little bit more resource limited, we were able to engage the patient and the healthcare system to be able to navigate both of that.
Yeah, thank you for sharing that. This is what the alternative regimens are per the guidelines for the OI guidelines. And you can see that there's still the preferred regimen is still the one that Aley mentioned, which is the 2-week induction. And so it's strongly recommended that this patient does stay and do this. And given the real life challenges of pill burden and then documenting for clearance and making sure that he's clinically improves, it can be challenging in someone who may not follow up, and we're just not sure. Although we want to respect his autonomy and his decision-making, this is a life-threatening disease as well. Currently, these guidelines are about to be updated in the next week or two, but currently the alternative regimen is listed as fluconazole high dose 1,200 milligrams plus 5-FC as an alternative, but it is noted to be inferior to the standard AmphoB induction. And so, Stephen, I don't know, did you have any other comments about this based on your experience?
No, I think, we've tended to try to compel individuals to stay in the hospital for the standard induction. Part of it is oftentimes these are kind of the initial presentations. And so you don't have the patient rapport and so on. And so it's, to have them in the hospital is an opportunity to kind of engage and develop a relationship. And so I strongly agree that the 2-week induction, if we can compel someone to stay, is important.
Great, thanks. Okay, so in this case, he is convinced you to let him go and agrees to come back. He gets the single dose. He's discharged with the fluconazole and 5-FC. He returns a few days later as planned, and he says he's taking all his medications. He's tolerating them well so far, and he notes that his headache has dramatically improved. Aside from documenting clearance, as you've discussed previously, you discuss his HIV diagnosis a bit further since it's a new diagnosis, and he's asked you for treatment. He's ready to start treatment. So this is an audience poll as well. So what is your advice to him regarding timing of ART initiation? Start today. He's motivated. Let's do it. Start after the completion of induction therapy for cryptomeningitis. Start in 4 to 6 weeks or other. And panelists, can you see the poll results? Great.
Yes, we can.
All right, let's give it a few more seconds and then. All right. right, let's stop the poll and share the results here. So 33% of you saying to start ART today, 47% say start after the induction, 20% saying start in 4 to 6 weeks. So, okay, panelists, let's discuss. What would you do in this case?
So I would, the guidelines say to wait 4 to 6 weeks because of the risk of immune reconstitution. I have, on occasion, if there's good follow-up and I am completely assured that the patient has normal opening pressure, has sterilized their CSF, I will sometimes personally push it to 3 weeks, but it would be I would be hard pressed to just start it in 2 weeks.
Aley, I have a question because you mentioned kind of some folks get frequent LPs and even get a VP shunt and so on. When you have somebody that has kind of a shunt in place, does that affect your timing?
Yeah, then that's a great question. I think then I would, and provided I knew that their CSF was sterile, I would probably then err on the side of actually like starting at 3 weeks, because the bottom line is that they need that immune reconstitution in order to clear their crypto. But the party line or the guidelines do state that you have to start in 4 to 6 weeks. So this is the slides showing the results from the COAT trial, which was a landmark clinical trial that looked at when to start antiretroviral therapy in people living with HIV who had cryptococcal meningitis. It was also done by the Bulwer group, which is like he's like the big cryptococcal expert around the world. And so the study was done in sub-Saharan Africa. Again, people with HIV with cryptococcal meningitis were randomized to either receive ART early, so within the first 1 to 2 weeks of their diagnosis, or late start, so within 4 to 6 weeks. And not surprisingly, there was a higher morbidity and mortality in the group that had early ART initiation. And actually, when you look, you'll see that for patients that had a low CSF white blood cell count, so not a significant CSF pleocytosis, if they actually received earlier ART, there was a far greater mortality associated with that. And this is sort of in line with what we know now, right, about cryptococcal meningitis, which is that these patients can often have very bland looking LPs, and that you should just never be fooled by that, because the fact is that these are the patients that when they reconstitute, they will reconstitute quite badly and have a very, very bad outcome. And so, but this was sort of the landmark study that kind of changed or sort of set our practice, which is that we now ideally we defer ART initiation for 4 to 6 weeks post after the diagnosis and treatment has been made. And that's kind of what Y guidelines says too. Do you all have any changes in how you would do this?
Dave, did you want to say something?
Yeah, I just think it's, again, counterintuitive to what we think about with a lot of the other OIs, where antiretroviral therapy is sort of the staple to help reconstitute the immune system. But again, this is really the outlier, and I think maybe that question again sort of trips a lot of us and needs to serve as a point of reminder that sometimes we need to have a lot of information before we dive in, especially when we talk about rapid starts. A lot of clinics, are sort of have this initiative to get people started the same day. They get on medications, and sometimes labs roll in, sometimes labs get missed. So I think this is an important point to make sure you have all your information, especially in somebody with a CD4 count that is slow.
And also to mention that there are antiretroviral guidelines surrounding CNS toxo and also the central nervous system tuberculosis. So it's just, I think in general, CNS opportunistic infections, it's important to kind of review the guidelines and look at timing of ART. Great.
One other point is that, Dave mentioned when these screening labs, and so if this patient is new to care, wasn't symptomatic, came in and had a positive cryptococcal screening antigen, would that impact your timing of ART initiation for this individual who's asymptomatic? And what would you do with that screening CRAG? Are you all doing screening CRAGs for patients upon entry into care?
Well, I just, I pulled this information out of the guidelines recently and sent it to the network of clinics that I'm part of. But, there is a guideline for CRAG screening for individuals with a CD4 count less than 100, especially less than 50, in the United States, even among asymptomatic individuals without evidence of meningitis. And my feeling is that we were probably under screening, that we were not, you saw an asymptomatic person with a CD4 count of 11, and we were not thinking, about this. But yeah, I think it's the screening test would prompt evaluation, including CSF evaluation.
Great.
Yeah, and say in Atlanta, I think, we just see a lot of advanced HIV, unfortunately, and even in very young patients. And so we've been pretty attuned, and we've just had very devastating crypto cases. And so we've been pretty attuned to it in clinic. And so our, especially when we have no sort of information on patients, like in general, I think, because it is a pretty inexpensive test and it's like an easy one to get, more often than not, I think most of certainly the providers in my clinic, including me, are just have a low threshold to just get it. Because the problem is by the time you get the data back, if you've already started the patient on ART, it's like, it's a problem because you have to get that LP first to rule out CNS disease before you can actually go down the induction or maintenance path. The maintenance pathway. So.
And we actually know from very early in the HIV epidemic that a serum test is a pretty sensitive test for cryptococcal disease.
Yeah.
Great. Okay, going back to this patient, when he is ready to start ART in 4 weeks or so, would you start long-acting injectable ART for this patient? All right. Let's stop the poll here. Okay, so 78% saying no, and 22% saying yes. All right, let's discuss.
I'll just say I agree with the audience. I think for a couple of reasons. One, when we look at the HHS guidelines for initial therapy recommended for most people, as Steve will get into in just a few minutes, we're now down to 3, of which this is not one of those combinations. I also would like to see a genotype prior to initiating this combination of medication, just because, again, with NNRTI resistance, again, with the lower barrier of resistance, the higher likelihood of failure. And also, I think just establishing some rapport with this patient, getting them engaged in care, getting them retained in care, and starting with that oral therapy where if there are some adverse effects or a new OI is identified where we need to adjust medication, we have that flexibility.
Great point, Dave. Any other thoughts about this?
Well, we can't access the drug in somebody who's viremic.
Yeah, and
Just
even if
the insurance logistics, yeah.
Yeah, exactly. And even if we could in certain situations, it takes 4 months here for us to even get approval for ART. So, even logistically, it's just impossible. So,
yeah, I echo that here. Logistically, it's impossible for us to. And to underscore Dave's point, it is not recommended in the guidelines. His viral load is quite high also. And so having all that data for the genotype in advance and knowing that information, maybe this is an option once this person gets suppressed as a maintenance drug for him. All right, we're going to move on to case 2 here. A 57-year-old man with longstanding HIV, well controlled. His viral load is undetectable, CD4 count 470, and he's on a fixed dose combination of dolutegravir, abacavir, and lamivudine. He just is presenting for a routine visit after his screening labs that he got ahead of his visit show hemoglobin A1C of 6.4, fasting lipids significant for a cholesterol of 245, an LDL of 130, triglycerides 175. He's otherwise well without complaints, and his only other medication is losartan for essential hypertension. His BMI at this visit is 32, and his blood pressure is 120/70. His 10-year ASCVD risk is calculated at 13.8 So this is another audience question. In addition to starting metformin for his elevated hemoglobin A1C, what do you advise regarding management? Changes ART and start a statin, changes ART, or just start a statin or other? Right, give it another couple seconds here. All right, let's stop the poll and see. Okay, so quite a split here. 38% saying change ART and start a statin, and 46%, so the most of the people are opting to start a statin, and 13% just to change the ART, and one person wanted other. So if you want to put that in the chat, you can, what the other is. And so let's have our speakers discuss this. Dr. Johnson, do you want to take the lead on this? And I'll show some slides to highlight his points.
Yeah, well, first of all, I think the audience is probably well aware of really the game-changing study, the Reprieve study that took individuals that might not qualify for a statin, living with HIV, and randomized them to a statin or placebo. And this study was huge, over 7,000 patients, and was stopped by the DSMB with a 36% reduction in the occurrence of cardiovascular events. And so a real game changer, and helps to underscore what we've known prior to that time, that we think HIV itself is an additional risk factor for heart disease through chronic inflammation and perhaps other mechanisms. The results of that study led to a working group from the antiretroviral guidelines panel, the IDSA primary care guidelines, the American Heart Association, and then the American College of Cardiology. So we put together a working group to publish these guidelines that are available online at the link that's provided there, to recommend initiating at least a moderate intensity statin if the calculated cardiovascular risk is 5% or more. There were actually benefits. There was some benefit shown in individuals whose calculated cardiovascular risk is less than 5%. Maybe move to the next slide there. And so there are some recommendations really that encompass a lot of individuals that are currently in clinical practice. The benefit in individuals with a lower cardiovascular risk is more moderate, but still, I think, an item of discussion among our patients. What we saw recently, we'll go to, and just some of you mentioned changing ART in addition to starting a statin. And this brings up the issue of abacavir, which is, obviously an older drug that we use less frequently, although because of the fixed dose combination of abacavir, dolutegravir, and lamivudine, there's a subset of people in clinical practice who's on this regimen. And one of the benefits of the Reprieve study is that there are many sub-studies and additional analyses in addition to the primary endpoint. And one was actually presented here at the International AIDS Conference in Munich, where there was an association with both current and former use of abacavir and subsequent cardiovascular events. And this is just a graph from that oral presentation at the AIDS conference and so on. If you look at a cross-section of most clinics now, many folks are on the fixed dose combination with bictegravir, or on the 2-drug combination with dolutegravir and 3-TC, or have moved to injectable therapy. But this study, which was really on top of a number of studies in the past that have suggested a cardiovascular risk, suggests to me that it may be more important to be more proactive about this. And I sent this information out to the 5 clinics that I'm part of, and and suggested that we look at everyone on abacavir containing regimens, have them come in for a clinic visit and discuss the therapy, discuss these results, and consider switches to other therapy.
Yeah, and I think, Dr. Johnson, your advice to your clinicians is similar to what the authors of the study also showed, is that controlling HIV is the most important, but based on these data and also data prior to this data from observational cohorts, that abacavir was linked with increased cardiovascular incidence, that avoiding abacavir if possible. But then, as if the guidelines knew that we were speaking today, did update last week. And so if you want to go through, and then I think Dave hinted at this as well, that the guidelines for the initial preferred regimens have changed.
Yeah, so the guidelines just came out here on September 12th and demoted the combination of abacavir, dolutegravir, and lamivudine. It was part of these for most people, and it's been relegated to other initial antiretroviral regimens for certain clinical scenarios. And I'm not quite sure what those clinical scenarios might be. I think we have enough kind of other medications that I think probably the use of abacavir is going to be quite limited in clinical practice, and that this current list are the 3 regimens that we should focus on for the time being.
I'm curious, Aley and Dave, if you're going to follow suit with Stephen here and proactively reach out to your clinicians and patients in your clinic to get them off of abacavir based on these new data.
Go ahead.
I don't have a ton of patients on abacavir, and if I do, sometimes some of that is like because of renal issues or something like that. And so, but also I think I would have to like think about it a little bit. I fortunately I have a younger subset of patients too, so it's something that I have to like think about it a little bit less. But I also think that some of my patients who are stably on Triumeq, I think it's just going to be hard to get them off of it, mostly because, as you know, like for people that have been stable on therapy for many, many years, they're just very reluctant to switch. Yeah.
I think that's a really good point. The reluctance to switch. I think for a long time, people will message your best regimen is your first regimen, people that have had HIV for a long time, and getting them to switch takes some time. It's not just a matter of, okay, it's time to switch today, and multiple conversations over visits. But I think this data is compelling to try to move the needle on some of these patients. Dave?
Yeah, and I don't disagree with that approach. And you know, the idea of having people to come in for a visit is actually to, you know, have a shared decision making on this. And there are going to be a subset of people that might not want to change. And if it's a young individual without other kind of cardiovascular risks and so on, you're going to probably feel more comfortable about that than if it's, you know, somebody with, you know, lots of risks. And so, yeah, I think I don't think it's wrong to continue, but I do think the new data make it reasonable to have a discussion about the data again.
Great.
And I think on the other side of the fence, there are a lot of providers also reluctant to change, especially down to 2-drug regimens. We've been hammered for a long time of saying 3 drugs, 3 drugs, 3 drugs. And now we have classes such as the integrase inhibitors that are extremely potent, high barrier to resistance. And going with a 2-drug combination is, I think, foreign for a lot of people. But because it is still a recommended initial regimen for most people, again, with the caveats listed there, we've sort of seen the writing on the wall with the abacavir and providing that education for patients and peeling that away and migrating a lot of our patients over to just the 2-drug regimens. And with that, have not had, with all of our conversions, have not had any issues with viral rebound, adverse effects, anything of that nature. So we've been able to do that with fairly good success. But we still have a handful of patients that again, are really holding on to that and struggling making that change.
There's actually a good comment in the chat from Christina about abacavir has good CNS penetration. This just came up a couple of weeks ago when I was on an inpatient service when somebody with an HIV encephalopathy, and the question came up whether to adjust antiretroviral therapy based on CNS penetration in that setting. Turned out he had a undetectable CSF viral load and so on, but I'm wondering, do the panelists consider that one reason to kind of keep abacavir on the list of options?
I generally wouldn't. I mean, I think when we look at the translational data from the CNS penetration effect or the CPE scores of these drugs, it's really challenging to translate that to clinical effect. But I think the fact that you had a viral a CSF viral load and again not wanting to rock the boat, and that being more of an issue than cardiovascular risk, I probably would have held on to it.
Great. Thanks for that great discussion and these timely recommendations to get us all thinking about abacavir in our patients and getting them off of abacavir. Okay, so we're going to move to case 3. A 32-year-old woman with asymptomatic HIV, CD4 count in the 700s, diagnosed as part of routine screening. She started on dolutegravir with emtricitabine tenofovir at her initial visit. The screening labs were significant for positive quantiferon. Chest X-ray was subsequently normal, and she has no pulmonary symptoms and no constitutional symptoms at all. She immigrated to the US from Mexico 5 years prior. So this is another audience poll. Lots of options here. For her LTBI treatment, what would you do? INH for 9 months, INH plus rifapentine weekly for 3 months, INH plus rifapentine daily for 1 month, rifampin daily for 4 months, or no LTBI treatment necessary. Okay, we'll give it a few seconds here. Great. Okay, let's stop the poll here. Wow, it's kind of a split here. INH for 9 months getting 37%, and INH plus rifapentine weekly for 3 months, 42%, and no LTBI treatment, 11%, and INH plus rifapentine daily for 1 month, 5%. Okay, so let's discuss. I'm going to go back, so just so you can, well, actually, let's talk a little bit about this. And Dave, do you want to take the lead on this and just talk about what are the indications, but then also the options?
Yeah, sure. Again, similar to I think the conversation earlier on in the presentation about doing cryptococcal screening, I think in some cases we sometimes miss the boat in screening for tuberculosis. Luckily, with the with IGRAs or the quantiferons or T-spots, whatever your labs have, we're able to do those with more consistency and better sensitivity and specificity than the TB skin tests. And it is important to note, as Shireesha has here in the slide, that I think one of the differences in persons living with HIV is the size of the induration. It's 5 millimeters in persons with HIV, and I want to say that might be 7.5 in those without. I'm not exactly sure, so check me on that. And then again for close contact with persons with active TB, we should be being more proactive with LTBI therapy. And again, these were just updated, as you can see, within the last 5 days. So for those of you that, again, with the smattering of answers, I think the first thing we need to talk about is that we have lots of options. And one of the approaches, given the combination of options and the complexity of drug-drug interactions, I think having some shared decision-making with patients is fairly important in these situations. But when we look at now the preferred regimens, rifapentine has moved up into preferred for both 3-HP, so that includes INH and rifapentine once weekly for 3 months. And some changes with this is that you can, with the rifapentine once weekly, dolutegravir can be dosed once daily. And you can use either tenofovir alafenamide or tenofovir diproxyl fumarate. And this is a recent change. And the reason why we see this is rifapentine accelerates the metabolism of both tenofovir alafenamide and dolutegravir. And because of that, it's really important probably to have closer clinical monitoring if you're maintaining your patients on these regimens. And obviously, again, in the US, we don't use a lot of efavirenz, and even in resource-limited settings, they're migrating from efavirenz to tenofovir, lamivudine, dolutegravir combinations. This still also raises how to manage those drug-drug interactions. And if we move to 1-HP, which is a combination of daily INH and rifapentine, this is where we would have to modify antiretroviral therapy. We can still use TDF or TAF, but the dolutegravir needs to be increased to twice daily. There are some studies that have looked at doing 100 milligrams of dolutegravir once daily, but that is not recommended given the variability in the pharmacokinetics. So those are our preferred regimens. Looking at the alternative regimens, and again, here, one other comment too is if you are going to use the rifapentine regimens, making sure that you work with your pharmacies, that you have a solid access to that drug over the full course of 3 months or 1 month, as sometimes it can be difficult to access in a variety of settings. And in regards to alternatives, still 9 or 6 months of INH daily is an option with no changes in antiretroviral therapy, or looking at rifampin, doing 4 months once daily. And again, in that case, needing to modify the dolutegravir to twice daily as well. And I don't know if I said this earlier, but also making sure the patient is not pregnant, as this can certainly modify drug selection based on teratogenic effects.
David, considering that the majority of people in the clinic would be on fixed dose bictegravir, branded as Biktarvy, what is your typical approach to switch?
That's a great question. And for patients that are really locked in and really like that, that can do the 6 months of INH, we have done that in a few times. But in a patient who's newly diagnosed and with both HIV and LTBI, I think you have a little bit more of the flexibility to say, hey, let's do this. We'll get 1 month or we'll do 3 months, and then we can modify your antiretroviral therapy after.
I think the big change here that came last week was that the 1-HP is now a preferred option. And as Dave mentioned, the dose adjustments needed, as well as the addition of TAF and not just TDF as options. So this is a pretty big deal, I think, for patients who are, especially because we're seeing, at least in our area, and I know in other areas too in the US, lots of immigrants, and we're seeing the screening QuantiFERON tests be positive. So having to address this, and previously we were offering INH for 9 months and now 6 months as a shorter option, but clearly that's a lot of time to be on an additional medication. And so having these much shortened options, particularly the 1-HP, is really a game changer for treatment, and ensuring adherence to that treatment is going to be a lot easier with these shorter courses. But noting that the dolutegravir is going to have to be BID.
And the patient would need pyridoxine as well.
Yes. Yeah.
So I want to make sure, I don't think I commented on that.
Yes, so anytime anyone's on INH, they need to be on B6 pyridoxine to prevent the peripheral neuropathy that can develop from INH. All right.
I would just add, Shireesha, that, I mean, I usually will just, I usually will give patients options. I will say that one of the challenges that I've also faced here, we don't have Medicaid expansion. And it's like sometimes changing the ART regimen gets complicated, especially if patients are on ADAP or if they're on like a lower tier plan on the exchange, and so on the ACA exchange. So that also kind of factors into my decision making, in addition to like giving patients the options of like, do you want to take a pill for 6 months? And obviously rifamycins, as we all know, and we discussed, have so many drug interactions. So if they're on other medications, it makes things complicated as well. But
yeah, definitely in terms of the other drug interactions. All right. Well, those were excellent points that you all made for these cases, and such timely updates in the guidelines to support some of the recommendations that you made. But here's a summary of the points. Cryptococcal meningitis treatment, a single dose AMPHO may be considered, but standard therapy remains the 2-week induction. Patients with low CSF white counts have a higher risk of immune reconstitution and neurologic complications from cryptococcal meningitis as a result. And then be aware of factors that are associated with increased risk of virologic failure with long-acting injectable ART. And we know that the guidelines don't support it at this time for initial therapy. And abacavir is no longer part of the preferred initial ART regimen for patients. It's now alternative. And then consider indications for statin therapy in patients with HIV. I think the REPRIEVE study, as Dr. Johnson mentions, really supports increased use of statins in our patients. And then remember the drug-drug interactions with latent TB therapy or TB treatment therapy, and note the new 1-month preferred option for treatment. So thank you to the panelists and thank you to the audience for participating in the poll. I see that there are some questions. One, just about metformin. I think that's a good point that you make. They don't have to start metformin, and it can be a mutual decision-making process for less than 6.5. And then someone commented about the initial patient whose car might get towed, and then working with social work to help with that problem. This was actually something that just came up in the hospital for one of our patients that prompted me to use that as a scenario for why they wanted to leave as a patient-directed discharge. So I think we often forget that there are lots of other things that are priorities for our patients besides what we think is the priority in the hospital, which may be a life-threatening disease, but we need to get we need to have a discussion about that to get our patients on the same side of why it's so important, but also to acknowledge that there are these other huge social factors that may be going on in their lives that are equally as important to them. So yes, but we lean on our social workers all the time for this sort of stuff, and they're an incredible resource. All right, thank you, everyone. And if there are no more questions, then I want to say thank you again to Steve, Aley, and Dave for joining today and for this great discussion.